Brian, you're muted.
I sound better when I'm muted. I'm sorry. I'll call a meeting of the February 17th Neighbors of Dunn County to order. The committee meeting, let the roll show that all members are present with the exception of Kelly McCulloch. He had something come up. And then we do have various staff. We all should add a chance to read the minutes of the January 20th meeting. Is there any questions? Or is there a motion? Yes, Mike. Mike, you're muted.
Just a small change, but before I do that, Chris has been doing a great job of the minutes, and I appreciate it because it kind of helps continuity. But on the administrator's report, part B, it said Administrator Meyer discussed CNA program. Kind of looks like we have a program. Could you just change the Administrator Meyer discussed requirements to conduct the CNA program? I think that's what happened. So we would add, I move or suggest we add after discussed requirements to conduct a CNA program.
Okay. Is there a motion to approve the minutes as changed, as they are and as they're changed? Motion by Supervisor Kinnear. Is there a second? Supervisor Jensen? Any other questions? Hearing none, all those in favor say aye.
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 Opposed? Carried. Krista, do we have any public comment?
No public comment.
Thank you. We'll get right into Administrator Meyer's report.
Thank you. As always, we start with the Quality Assurance Steering Committee updates. This month, we went over the Quality of Life Committee, which the Quality of Life Committee is a committee that goes over the overall quality of life of a resident. So we talk about everything to do with their everyday life. So food, medical care, complaints, concerns, business office, as well as we look at it from every angle. So we have staff from every department as well as every level of staff on that committee to look at the overall quality of life of a resident. So that was their quarterly report this month, as well as we had our new medical director for his first quality assurance meeting. So we do have a new medical director at the Neighbors. Dr. Michael Phillips has been with us for a couple of weeks now. He's been a rounding physician with us since I believe it was October or November. And then Dr. Nogler was a temporary fill-in after Dr. Brown's retirement. And now we have Dr. Phillips as our medical director. So this was his first QA meeting and we're happy to have him on board with us. Any questions about QA? All right. Next, I'll go to the staff report regarding competitive wages. So this was something that was sent along with the financials that came out, I believe it was yesterday. So as you can see, there's a couple page staff report. I don't know if everyone had a chance to read it, but I will go over kind of the key topics in the staff report. This was brought up based on a couple of different things from previous meetings of this committee's conversation, as well as what's going on in our market with the conversation of wages. So we have heard in recent weeks or the last month or so of a couple of local nursing homes that have been offering fairly substantial wages that were higher than what we can offer based at this time. There's other things related to that about if they're offering that for a new hire, but not compensating their past employees like we do with anytime we have a new hire, we look at our past employees' wages or our wages that our current employees have and make sure we're not costing anyone out. So there's a couple other things to that, but we have had some word that there are nursing homes in our area that are offering higher compensation. And I know it's been the directive of this committee and the county board to make sure that we're offering a competitive wage. So that's what kind of stemmed this staff report. It basically is giving information of what's currently happening with both other nursing homes in our area, as well as competing with the travel agencies. So as you're well aware, we do have travel staff here that we pay a fairly high ticket dollar amount for. The hard part with that is that in previous times, travel agencies hired from all over the country, which they're still doing, but there wasn't much local staff that worked for them. Now, because of the need of agency staffing in all skilled nursing facilities, and to be honest, all healthcare entities, they're hiring up everywhere, and now there's no need to travel. So people who are travel staff or pool staff are living and working in their neighborhoods that they already were before. So that's kind of changed the atmosphere of the draw to be a in-person or a staff member that's hired directly was you could work where you live and you didn't have to travel. Now everyone's using agency staff, so you can work where you live and be a travel nurse or CNA. So that's added some added complexities with not only competing with local nursing homes for the local staff, but we're also competing with the travel agencies more now. So that's described in here, as well as the overall concept of the current wage situation that we're having. No matter how often we do wage analysis, that information takes some time, and by the time we get it, it seems like it's out of date. So even with our recent wage compensation class comp study, it changes on almost a weekly basis. It's basically going to the point of people are offering whatever they can offer to get people in the door, which is something that with our structure just isn't feasible, as of having to go through multiple steps to offer a different wage, which is just part of the nature of a government entity. On the back side of it, we went into a couple of different discussions and ideas that we've had, which we are working on costing for some of them. Probably the most immediate one that could change that would potentially make a greater impact, especially for part-time employees, is the in lieu of fringe. Currently, we offer in lieu of fringe plus a retention bonus, basically is what is a retention pay. So in lieu of fringe for the county is $237, and then neighbors employees get an extra $1 that goes with that for recruitment and retention. That's currently offered at the first of the month following a 30-day wait. So the maximum amount of time that could take is 59 days post-hire. So almost 2 months post-hire to have that kick in. So if we're offering, say, $16 an hour roughly to a new CNA, in reality, with that extra in lieu of fringe incentive, we could be offering close to $19 or $19.37 for a new CNA, which would be competitive with that $20 rate that we're seeing some other nursing homes offer. So that was one idea we had of having that kick in right away instead of having it wait. That would need to be a change on the overall county level because that is a county policy, not an NDC policy. But it is an idea that we have worked with Heather and HR to kind of figure out a different approach than just simply changing wages as well. So there's a lot of information there, and it kind of goes with a lot of different topics, but it all revolves around nursing wages and that what we're doing to try to combat that at this time. I'm sure there's questions.
Anyone have any questions?
I've got
Well-
a comment, not a question. I think this was very eye-opening for myself. I really thought it was a very good report. It
Yeah, I
doesn't,
agree.
it doesn't create a very nice picture. A lot of hurdles for us, but I thought the report was very good, and I needed to hear that. Thank you.
It was a very good report. And what is your feeling on moving forward with this, Carmen?
Well, there's no action item on this report today, since most of these things are things that aren't NDC specific. All of this would be actually through Committee on Admin, I believe. Heather or Paul could correct me if I'm wrong on that, but the one thing we could, I believe, could do would be endorse this to go to admin committee, different ideas with this. But at this point, it was more for information purposes to see what we're currently working with, and then to maybe if there is something that you would like us to cost out or have an action item on our next committee meeting. But this was more for informational purposes, and then that in lieu of fringe conversation as well, since that is something we thought of that could have a pretty immediate effect. It's for part-time employees, which we do need as well. We do obviously also want to hire full-time, and this would only affect part-time employees, but it would be an ability to actually say we're offering this at the start, because we commonly have people that come, they see this as a benefit or whatnot, and then they get 30 days on the road and like, well, why haven't I seen this increase yet? Well, it's 30 days and then the first of the month. So it could be up to 59 days. So it just would be another marketing strategy that we could have for recruitment.
Yeah, I understand that we can't take any action, but if you feel strongly about this, I think we should possibly look into it and bring it back to the committee next month. And is that going to be too late? What do you do? Just wherever you go, that's all you hear. You can't, no one can get help. So, but we got to stay competitive.
Mhm. I believe what the idea would be to have an endorsement from this committee. I don't know if that's something that can be done without an action item, but to have this brought to admin committee, because I don't believe that any of these could be decided at our committee, if I am correct.
Paul, can you help us with that?
That is correct. It would be appropriate for this committee to recommend if it feels, and that would be taken into consideration.
So in other words, all we need to do is give our thumbs up. Correct?
Essentially,
Can't vote
yes.
on it.
It's a specific recommendation, but yes.
Thumbs up from the committee. Thumbs down. Looks like we want to recommend this, Carmen.
And could this be, I know the agenda just came out for next week's admin committee. Could that agenda be amended? Because otherwise it would be probably not going to county board until April, if I'm right. If we could amend the admin committee this next week agenda to look at this. I don't know if that gives you enough time to have all the information prepared, but then it would be able to go to county board in March.
We can amend the agenda. That could be amended up to 24 hours before the meeting. So Carmen can provide to me the detail. It'll also give Heather Murray an opportunity to prepare anything from a broader perspective that may be necessary for the committee's consideration.
Okay. Does that work?
Yeah.
Okay.
Is there any other questions or comments on this topic? Okay. If not, I'll go on to a similar topic. Chris is actually out today, so I'll be going over the employment report. So very similar to every month. So we had the neighbors and NeoGov as our recruitment efforts. We've also been using Facebook a lot to put out recruitment efforts, both through the county's Facebook as well as the neighbors' separate Facebook account, which actually has brought some more attention to it than just online. So that is something we've been doing, as well as I know Chris also utilized a different resource that was primarily for Homemakers as a recruitment resource. I can't remember the name of it at the moment, but it's for people that are seeking employment through different avenues because they could not find employment. So primarily not people that have licensures or certifications and things like that, but if they could fill homemakers or kitchen positions. So I don't believe we've had any applications from that, but trying different avenues to see if we can get any more applications than we have been. We had 21 interviews scheduled this month, 7 of which were agency. 21 interviews were held. We offered 5 positions and 5 positions were accepted. Part of that was due to having applications for positions that were only one position versus CNAs and nursing positions. So we had a life enhancement activity or activities position open, as well as the scheduler position was open. So those positions had multiple applicants for one position. So that's why that interviews held is so much higher than the positions offered because we had multiple applicants. We had 5 positions accepted. 0 of those positions were offered higher than a step 3. We did have a few resignations this month as well. We had a part-time CNA accept employment at a different nursing home. We had a part-time CNA looking for employment not related to long-term care. Part-time CNA health issues with a child, wasn't able to make the schedule work. Part-time CNA healthcare was not a good fit. We had a full-time CNA move to Texas. We had a full-time cook confused with the position. They thought they were working in a different position than what it was and wasn't happy with the current position. We had a part-time cook resign due to conflicts with coworkers. We had a part-time life enhancement assistant that was a child care of a grandchild, and then a part-time homemaker that wanted employment outside of healthcare. As you can see, the open positions were adjusted to reflect that, both in and out. And then we also had active leave of absences if there was any changes there. We did not have any work comp lost hours this month in any positions. And then we had 93 shifts, or roughly 740 hours lost due to COVID this month. We have seen substantial uptick in COVID cases with staff again, as we've talked about the past couple of months. This past week or two has kind of leveled off a little bit, but the month that would be in this report was quite busy with having people out to either be tested or because of being COVID positive. So hopefully we're heading in the right direction with that, but we still are having to have lost hours due to COVID situations, whether it be symptoms being tested and being out until test results or actually having COVID as well. So that continues to be an issue that we struggle with almost on a daily basis, of having someone call in because they have whatever symptom it might be. Pretty much all illnesses now, any symptom that you have, we have to have them be tested. So it's almost been 2 years now that we've been doing that, but a headache, even if you call in for a headache, you're tested for COVID. So we have lots of lost time due to COVID or symptom related situations. Any questions on this at all?
Well, yes, this is Mike. I do. This is where I usually ask you about CNA course.
Mhm.
And we're still where?
So the newest information about this is, I believe a couple of months ago, we talked about that we had reviewed a different training plan that would be primarily done online. So we have been in contact with that company. The biggest issue with that was that it hadn't been approved yet to be used. But one nursing home locally actually just did get theirs through that program approved. So I've been in contact with that company. They basically have a preset training program, so we wouldn't have to develop a curriculum. It's primarily done online. And then there's some still staffing or scheduled hours here that would then be hands-on clinical work. So that would actually be here. So they wouldn't lose that clinical aspect. That's very important for becoming a caregiver or a CNA. But it's primarily done online. So we are in contact with that company so that we wouldn't have to reinvent the wheel. So I'm looking to set up a meeting with them in the next week or so to have an actual conversation about what it would look like for our program.
Okay, thank you. And, I remember Dr. Brown telling us that over in Elmwood, there was a CNA course with 8 or 10 or 12 people signed up, only one finished.
Mhm.
So I recognize this is not a cure-all, but I really encourage you to keep doing what you're doing there and see what we can do with it. Can't hurt.
Right, I agree. At the meantime, we are still having CNA and nursing students here that are through our own program, so that's beneficial as well. So until we get that in place, we'll continue to have that through CVTC. Even after it's in place, we would still have the nursing students, but we still do have students here that get to do their clinicals here, which is great exposure. And commonly people stay where they are comfortable. So if they then want to work in a nursing home after they pass their tests or graduate or whatever it is that their program has, we do commonly see some people start off here because they're comfortable with the environment, the residents, everything like that. So that is beneficial. Any other
Sure.
questions? Oh, Steve?
I have a question. I was wondering if there's still reimbursement for the COVID testing and lots of work time.
Yeah, so we are still having reimbursement through the provider relief funding for anything related to COVID. So anytime we have COVID related expenses, losses, things like that, we do try to keep really close track of all of that. So we can accredit that to the provider relief funding that we receive from the government.
Mr. Chair,
Yes, Dave, go ahead.
couple of questions. Just so I totally understand this, under the CNA, you've got 53.7 full-time, part-time, and 8. So that's 53 open positions, and you've filled 18 of those with agency help. That's the way I'm reading that?
Correct.
Okay, that's what I thought, but I just wanted to make sure. And then my other question is, I see you've got on here 6 part-time homemakers. And that reminds me, having the homemakers, has that helped with the CNA stuff? You know, now that it's been a few months,
Mhm.
I see you shaking your head, so you must feel it's working so good.
So yeah, we do feel that it has made an impact, especially on just the time that it takes to serve that dinner meal is probably the biggest thing. Of staff being able, CNA staff being able to assist residents during that time, as well as it's extremely helpful on the days that we simply can't fill a shift or someone has to stay later, things like that, that we have an extra set of hands there to do the things that you don't need to be a CNA to do, but they help out and take some stress off of the CNAs on those days. So we've had a lot less complaints from the PM staff about the stress of getting everything done and making sure resident care still occurs during that dinner meal too, which is a really important part of that. Because now they're not juggling too many things and they can take someone to the bathroom or help them out or whatever it might be while the homemaker is serving that meal. Oh, sorry, go ahead.
Well, everything you've just said, it has to do with actually better service for the resident. But do you also feel that it's helped maybe keep a couple of CNAs that might not have?
I don't have a specific thing that says yes or no on that, but my reaction would be yes. We have it on our
Okay.
exit interviews. We haven't had any that say doing too much on because of serving meals like we were having before. That's the
All right.
only actual, I guess it's not data, but anything that we can actually compare it to. So I guess we've had less complaints from PM staff about that situation, which would be my indication that it's getting better and that it's not obviously perfect. It's still a hard job and there's still a lot to do, but we've had less staff having issues with, I have to be doing this while doing that kind of thing and burnout from that situation. So not hearing about having issues with that is definitely a positive.
Well, that's good. It's nice to know that something we did might have helped.
Mhm.
Thank you.
Right. Carmen, I have one question. Now, on your open positions, are they open shifts or actual open people? No,
Open people.
positions. They
Open
are.
people. Mhm.
Boy,
Yeah, not positions.
okay,
They're not shifts.
yeah. Anybody else have a question on that? Paula?
Oh, yeah, can you hear me?
Yes.
Okay, perfect. So I was just gonna comment on that as well, where it said 53.7 full-time and part-time CNA positions and 18 full-time are filled with agency CNAs. So we're only staffing to the point of, we have 2 houses that are still closed because we can't get enough staff to open up those other houses. And with that being said, the agency staff that do come usually end up working 40 hours of overtime every week. So it's like we're paying them 1 person to do almost 2 persons' jobs. You know what I'm saying? Because it's like they pick up all kinds of overtime. It's crazy. But if they didn't pick it up, we wouldn't be able to even keep open what we do have open.
So a lot of them are working 80 hours a week?
Oh, yeah. I don't know how they do it. Yeah, it's like they like, I came to work and that's what I'm planning on doing. I don't have anything else to do, so I'm just planning on working. And when Chris and I do interviews with agency staff, almost all of them, and Carmen had commented on this before, a lot of them are coming from Eau Claire area, Mondovi area, things like that. So this is the first time that they're traveling because they've heard it from other people that traveling is great. You get extra money, you know, this and that. And like, if you don't have to use the money for housing, then they're making a lot more money.
80 hours a week, that almost sounds like farming.
Yeah.
Getting close, Mike, getting close. Anybody, anything else? We'll go on to the referral report then.
All right, so we have our referral report. So it looks pretty similar to the last couple of months. So as Paula mentioned, we still have Arrowhead and Deerview closed. At the beginning of the month, we did have 93 residents. We had 132 referrals. So as you can remember from probably last couple of months, that we have had an uptick in referrals, primarily due to lots of nursing homes not accepting residents for various reasons, both due to staffing concerns as well as COVID, having a bigger impact in the last couple of months than it did over probably the last 6 months. So we did have a ton of referrals as we have in the past couple of months. We did admit 9 residents to the facility. We had 123 residents not admitted, with 4 of the referrals are still in the hospital. So that's why that doesn't completely add up. So we did have more admissions this month, and we have continued to do so as well. Part of that is due to us having some people pass away and filling beds, and some of it is people coming back to us. So we are still maintaining having 2 households closed, as well as the amount of residents that we can actually take care of with the staff we have. So we aren't exceeding that limit to having staff mandated and having shortages and things like that. So at the end of the month, we had 95 residents, with 3 residents transferred to another facility. Those were assisted living, so they're transferring to an assisted living. And we had 5 people pass away, and we had 2 discharge home. So we did not have anyone go to another nursing home. It was going to an assisted living in town, which is a lower level of care. At the end of the month, as I said, we had 95 residents. Today, we're at 98 as our census, with 1 resident in the hospital. So 99 would be our number of beds filled at this time. So we have had a bit of an uptick in census, which is good. Like I said, we're still maintaining it to the point that we can adequately staff without having an extra burden on the staff. We have at times had conversations about opening one of the households, but at this time, we just do not think it's feasible with the staffing situation. So it is something that we do look at on a regular basis, with between myself, the nursing team, as well as the social services team, discuss this probably on a weekly basis to see if we're at the point that we need to consider opening, if we can consider opening, based on our availability with staffing. We also have had, per our situations with COVID, we have had some times that we haven't been able to admit. Currently, the East building, which I'll talk about later, is not able to admit at all. So we do have some open beds there, not able to admit. Central, for the household that's open, is completely full. And then West is completely full, with the exception of some memory care beds. So we typically do not admit people to the memory care households that do not need memory care, as that's specific for people with memory care concerns. So those beds, even though they're still open, we wouldn't necessarily fill with a short-term rehab person. So we do have some openings in West and East in memory care. But besides that, we are pretty much at our capacity for what we can staff at this point. Any
Any questions? Steve, go ahead, but you're muted.
Yeah, I was wondering, you can say like what comes first, the horse or the cart. And I was wondering, like, opening up another building with clients, what would determine that? How many clients do you gotta have to open up a new housing? And then how many employees do you have ahead of the clients?
Sure.
How does that work out?
So the last time that we opened up another household from being closed was a couple years ago. We reopened Arrowhead after it had been closed for about a year. So at that time, what we look at is we try to have it so that we have, well, first in this situation, we would need the staff. So we review our staffing and see where we're at. If we're getting to the point where we're currently at and our regular staff, we're having extra people on the schedule, things like that, based on, we're having to give people a day off, basically, that wouldn't normally be their day off because we don't have a place to put them, which would be excellent news at this point, that we would have excess staff for what we currently have open. That would be kind of when we're like, okay, now we can open up another household because we have excess staff for what we currently have, versus what our regular situation has been now is trying to fill because we don't have enough staff. So that would kind of be our cue that we can now look at opening another household in terms of staff. We would still only staff it to the amount of people, which would originally start with probably having one staff member down there on every shift, because you can't have 8 or 9 admissions in a day to have it be even half full. That's just not feasible for the nursing staff to do the paperwork for the admissions, as well as it just doesn't necessarily provide the best care. New admissions take a lot of extra time, help them acclimate to the facility, and there's a lot of assessments and paperwork and things like that. When we opened Arrowhead a couple years ago, I believe we had 4 admissions in a day was the most we did, but in the course of a week, we had about 8 admissions. And we calculated out that we had the availability with the admissions, we had the staff availability, and we knew we also staffed extra nurses on those days to help with the paperwork and get those assessments done. So opening a household is a large undertaking, and it's a big process. And we hope to get to that point, but it would take the staff first to do so.
So with staff putting in 80 hours a week right now, we're really behind the ball on reopening another house.
Yeah, at this point, we're not going to be opening another house unless we have more staff hired. So it's something that we review almost probably every week. It's a discussion that we have, since we do have the referrals and the availability, and we don't really have the beds outside of those 2 closed houses at this time, with the exception of those memory care beds. So we do discuss it on a regular basis, but at this point, we're not to that point.
Okay, thank you.
Paula, you had a question or a comment?
Yeah, I was just gonna say that, as far as Carmen's right, we do talk about that all of the time, as far as like, do we have enough staff to open? The thing is, even with the agency staff, some of them are only here for 8 weeks, some are here for 13 weeks. We never know if they're gonna extend until maybe the last couple days of their contract. So it's like, we're always in limbo of whether we're gonna have enough staff or not to even cover what we have. It would be great if agency would say, yep, I'm going to stay there for 6 months, and, you know, things like that. And we'd be able to plan a little bit more ahead, but it's a revolving door with agency. We have people coming and going all the time. Carmen's doing a good job with keeping it at tow, so she's doing good.
Okay. Moving forward. Scott, I see you're here.
Yes, I am here. I don't have a lot on the facilities or the environmental report. Been working with the company that installed our fire alarm system so that we can get our annunciator panel installed for the federal look back survey, getting compliance with that. Other than that, staff have been working on the typical work orders and keeping the mechanicals going of the building. Otherwise, nothing real out of the ordinary, just average stuff, nothing very exciting. Any questions?
No snow to get off the roofs?
hasn't built up with snow or we've seen a problem yet, so that's a good thing. We'll
Yeah,
knock
it's-
on wood that, it's good.
Been a good winter for that, that's for sure.
So far, yes.
Nothing else? Go ahead, Carmen.
All right. Well, it's Scott didn't mention is currently we're working on the call light system that has been repetitively beeping outside of my office for 4 days, but just giving you a hard time. So
Maybe I'd let you give the details of that one.
So on the survey activity report, so as Scott mentioned, we did have to replace our enunciator panel from that federal survey. So we did an IDR, so an informal dispute resolution, which is basically a nursing home's way of fighting a citation. We did not win the IDR. They said that the citation stands. So we are replacing or adding in a new enunciator panel that will be at a staffed 24-hour location. So Scott and his team have been working on the process to do so. So we are working with CMS on basically an extension from our compliance date, simply because that enunciator panel is a rather expensive item, as well as the installation takes some time. So we did not order one prior to hearing back from the IDR. So once we heard from the IDR, that's when we ordered one, which takes some time to get in or work through that process of ordering one. So they do offer extensions because they don't expect us to fix the problem while we have an IDR out there, basically. So we are working with them for that paperwork, basically. So that will conclude the federal look back survey for Central's life safety code survey. So that's kind of wrapping that one up. And then I believe last month we had discussed the West complaint survey that was still open at the time. I believe that was the same week as this meeting. So that did close, and it was unsubstantiated with no citations. So about 2.5 weeks after the surveyor was here, she called me to notify me that she was closing the survey and did not have any citations for us. So it was unsubstantiated complaint. So that one is now finished as well. Any questions about the survey?
Must feel good to get a call like that, huh?
Yeah, we're waiting patiently, or maybe not so patiently on my end, but to hear back from them. Typically they leave that day and we know when they're leaving. So to have it hanging out there for a couple of weeks was kind of daunting. So it felt good to have it over with.
That's good.
Our next survey will most likely be in the East Building for annual survey, which our East Building has theirs in the spring, early summer timeframe. So we would be expecting them sometime between like April and June is our anticipation. So that will be our next annual survey. All right. And finally on my report is COVID-19 update. So as always, give a COVID-19 update for how it affects the neighbors currently. So our most recent situation is we do have in the current outbreak that it did involve residents. So we did have 4 residents test positive for COVID in the East Building. This has been going on for about 2.5 weeks now. So we had 2 residents that tested positive that have since come out of their isolation and they're considered fully recovered. No significant symptoms or issues with either of them. We have 1 resident that will be coming out of their isolation tomorrow and has not had any significant issues. And then our 4th resident just started their isolation period this week. So far so good, but we'll still be in isolation for another 1.5 weeks, approximately. So, or a week or so. So we have had, like I said, 4 residents. Several staff have also tested positive. We believe in relation to this outbreak. It's kind of hard to determine necessarily who gave what to who, but we have had a few staff as well test positive in recent weeks that have worked in that facility, that part of the facility. So we are doing everything to mitigate the spread, N95s for all of the staff that are working in those rooms, and trying to do extra cleaning and everything else like we have in our past outbreaks as well. So this is our first true outbreak since we had of residents since our major outbreak last year. So it was not necessarily a pleasant thing, but luckily everyone is doing okay at the moment.
So the
Carmen,
residents
for
aren't
the-
getting as sick as last year at this time? So,
No, so we haven't seen any real true bad symptoms. Really, it's been cold symptoms, common to what we've heard in the news or in the media is that the current variant is much less severe. It is very contagious, as we all know, but so it does seem like people are getting it easier, especially with how we're thinking about the potential contacts of different people in this situation. The people that, one of the individuals especially that was sick, barely uses any staff help. So even if a staff member is going into their room, they're very independent. So the likelihood that someone spent 15 minutes in their room or he was even by 15 minutes is very unlikely. So it just goes to show how contagious this can be, and it doesn't take much exposure to have COVID. But luckily, we haven't been seeing very many significant symptoms, cold symptoms, even things that just show up as their usual, a small cough. And we are very diligent about testing residents, even with a small symptom, no matter what. So we've been fortunate to catch some of these that maybe wouldn't have been thought they were anything because they coughed a couple times or just didn't seem like themselves, things like that. But fortunately, no severe illness at this time.
Were the residents vaccinated?
Some were and some were not.
I have
Steve?
a question. What is the protocol now on how many days are they isolated if they are tested positive, and has that changed?
Not for nursing homes. So the general public did change for isolation periods inside a nursing home for both staff, residents, and visitors, actually. We have kept the same standards. So there are situations that if we are in contingency staffing or emergent crisis staffing situations, that staff exposure and quarantine and isolation times can be adjusted. We're currently using the conventional method. But for residents and visitors, we have to use the conventional method, which is 10 days from symptom onset or positive test. So the residents are isolated for 10 days if they test positive.
But the rest of the residents can have visitors?
Correct.
Okay.
So I believe that was in this fall timeframe that changed. So I believe it was November that the visitation policies changed, that we cannot restrict visitors. The only time that we can restrict a visitor is if they are either within their quarantine isolation period or are symptomatic or currently positive, if they were would give us that information. But we do still screen visitors when they come in. So the only time we could restrict a visitor is if they didn't pass the screening. But any resident, including the COVID positive residents, can have visitors.
So every visitor that comes in gets tested?
No, screened.
Just screened?
Yes, just screened.
Okay.
So screened for symptoms as well as questions about exposure, potential exposure, if they've been tested in the last few days or if they're the pending, anything like that, that would potentially have them not be able to be a visitor at that time.
So we have to rely on their honesty.
Mhm.
Yeah, okay.
Maybe this isn't the place or time, or maybe no one can answer it, but is the Delta variant still out there as strong as it was a year ago?
So I'm probably not the best person to answer. Unfortunately, KT isn't with us, but based on what I know and have read is that they believe that most, if not all, of the current COVID out there is the Omicron variant. So basically, and I'm not an expert by any means, but from my understanding of epidemiology is that typically when there's a new variant that overtakes the other variant, then it becomes the main variant. And then pretty much erases the past ones. So I believe that is what happened from Delta to Omicron.
Okay, okay. Do you have anything else to add, Carmen, or
I do not, unless anyone has any other questions for me.
questions? Seeing none, we'll move on to the vouchers. Hope you all had a chance to review them. Are there any questions on the vouchers? And seeing none, we'll get into the financial report with Jane. Good morning.
Good morning, everybody. Well, we can dive right into it. I'll take these in order of, in the order that I had them in, that they are in the packet. So the aging summary is first this time. It's a little different. I tried a new format and not sure if it came out the way we want it, and I will keep playing with it. But the outstanding balance as of January 31st, actually it said, does your form say 12/31/2021 at the top?
Yes, yes.
Okay, then I sent you the wrong form. I sent the wrong attachment. So ignore all of that, but do you like the format?
I do. Honestly, I do. It's easier to read.
Okay, I will play with that and give you something updated. It is very similar to the prior month. We haven't been getting paid on any of the large outstanding balances, but the payment plans we still collect on. Of course, with lower census, we don't have as much going into the aging report, but we should be keeping up and getting it down further. But I do have two new staff, well, one new staff person and one relatively new staff that's been here a year. They're taking on more responsibility with the billing and the aging process. So I think we are in good hands that way as far as the billing activity. Any questions on that?
I'm just wondering, Jane, could you, before we end the meeting some way, somehow, could you just get us the balance for the end of January? That's all I would
Yep.
ask. Okay,
I can certainly do that. Yep.
thank you.
Sorry
And
about
just
that.
A question, Jane, what do the negative numbers mean there for the 91 to 120?
They balance out, and that's why we were looking at a new report because of some corrections that we made to our software going back to January as far as the contractual adjustments and getting real revenue numbers where they should be. And that threw off the aging report, and we're not able to correct that. So I'm trying to work around those numbers until they clear, and rational numbers is what you want. And all that, it's not good that the system is not working with me on this one. Yeah. However, when we talk about the Medicaid dollars and how we calculate those, the new Medicaid payment system was implemented in January. Instead of a flat rate for all of our Medicaid patients that's updated every quarter, we now have a model. State of Wisconsin is the first one to go to this model nationwide. That each Medicaid resident will get their own rate. So based on their scoring, similar to Medicare A, they have a score, and we bill on that score. Medicaid verifies it with our MDS scores submitted, and they pay us a different rate for every person, and that rate will fluctuate throughout the year. And then if we do have less revenue on Medicaid, there is a way to receive compensation. But I believe we're better off with the new rates. So we'll see how that pans out. I'll do some analysis on that next month to compare where we would have been versus where we are. But that system is implemented. Some software systems are not doing well. Ours is pretty good. We've gotten paid for most of our Medicaid claims in January. So it was a rough launch, but we got there.
I would just add that the best part of that new system is that we're truly getting paid for everything that we're doing for the residents, instead of more of it being an average, which sometimes in the averages you might luck out and your capturing something that was super high dollar and now you're getting paid for that for someone that costs less. But sometimes it also goes the other way when you're now paying something more and you're getting or whatever it might be. The law of averages doesn't always work in our benefit, especially if, say, the person that was there that costed more was there longer than the person that costed less. So now we're getting paid truly for what we're doing for each resident, which should also help with just being able to budget and everything like that too.
Yeah, I agree. And the update from Medicaid would be a rate adjustment, like almost a year later. They would review those acuity scores and then adjust the rates about a year later. So it was very indirect. Yeah. Another update on the Medicaid front. I attended a leading age financial managers meeting this week and asked the question about the supplemental payments. The county homes get a supplemental payment to offset extra expenses that we have incurred. Privately owned county homes can use their tax money as an expense. So we get something else that's different. So it's not really unfair that county homes get this, but my concern was that these COVID dollars might eat into our supplemental payments next year. I asked the question because we're going to have some big money posted for lost revenues. Will that catch up to us in 2 years? And they couldn't answer that. The people from the state did not know. In June and July, when they do some budgeting, the topic will come up. So I'll keep you up to date on that, and we'll know how to budget in 23 based on that. The supplemental income is a big part of what we get from Medicaid. And if they cut that back, we'll be in trouble. So that's something to keep an eye on, and I'll keep you up to date. That's Medicaid. Let's go on to the pool staff worksheet. Not a whole lot of data there for January. Some of our bills got put into January that should have been in December, but we'll get that all worked out. Still, the year-to-date average, just January, is $161,000, where in 2021, the monthly average was 144. So we are using more staff from the agencies. I guess that's just the proof that the bills are there. So it is getting costly. Any questions about the pool staff numbers? Okay. Moving on to the income statement. January and year-to-date will be the same because it's the first month. Our private pay revenues are spot on. Supplemental payment seems to have been over budgeted just a little bit. We'll get a new amount in July, so that should hopefully correct itself. The revenues were down, 18%. We estimated $1.2 million and we got $1 million in actual revenues. As for the expenses, they seem pretty much in line. Administration is high. We posted some insurance annual bills to that cost center. Going down to the bottom, we're 20% less on our expenses. So it kind of evens out, 18% less in revenue, 20% less in expenses. And then we add that depreciation that isn't posted yet. And at the bottom, we come up with a net loss of about $29,000 for January. Any questions?
No, but I see there is no COVID reimbursement in There likely
No.
will be, correct?
In January, there hasn't been, so we started that over. The COVID reimbursement, that is posted now to December, we were able to put $635,000 of lost revenue towards 2021.
Good.
That's a lot of money. So we had over $1 million in 2021 in COVID revenues. What's left now of the provider relief funds is $307,000 for the rest of the year. And behavioral health and public health could tap into a few of those dollars, but it's mostly NDC dollars. So if we say $300,000 for this year, we'll certainly have expenses to match that. And then it's done.
Right, right.
Yeah. And then is there more to the meeting, or do you want to wait until I get that aging report data for you here?
No, we don't have too much more. No.
I can get it real quick here.
Okay. Are there any other questions for Jane while she's looking? Paul, Dave, go ahead.
Well, Jane, you mentioned that our supplement reimbursement may hinge on what we've got for COVID dollars. And all the other nursing, even private nursing homes got some COVID dollars, didn't they?
Yes.
Okay. So if we all got, the ability to put in for COVID dollars and use them, hopefully they won't affect the Medicaid supplement for just county homes. If the private homes could get the COVID dollars, I understand your concern, but I'm hoping that if all nursing homes could get COVID dollars, then it shouldn't change anything the way it was. So we should still get our supplement. I would hate to lose our supplement to the tune of up to $1 million of what we got in COVID dollars last year. That would really hurt. So anyway, I'm just throwing that comment out there. I don't know if we should I guess we'll have to listen to you, and then you keep us informed, and if we have to really pound on our legislative people, we'll have to do that.
Thank you. Yep. And the good news with Leading Age, our association, is that they have a new director that at least the financial piece of it. Renee Eastman, that was the rate setting, what I call her guru of DHS, has been brought on to Leading Age. So I've worked with Renee in the past. She is an attorney and she's a CPA, and she's working for Leading Age, and she knows so much about this rate setting and what the homes need. I think we're in good hands with her advocacy, and she knows the politics and the lay of the land in Madison. So at least we have what I consider a very good advocate there. But the policy setters are who they are, and if I hope they come out on our side to keep a supplemental payment. The idea of supplemental payment, though, is to reimburse for losses. So if we can't show operational losses versus a capital loss, I don't know if they're going to get down to that level, but we'll do everything we can to keep our supplemental payments. The total outstanding balance for end of January 31st, 2022 is $1,100,000. So it went up a little bit. And mostly in the Medicare A section, because our payments, some of those didn't come in until the next month. Medicare A is a big hinge on what posts at the end of the month or the very first week of the next, depending on when the claims go in.
Thank you, Jane.
Mhm.
Are there any other questions for Jane? If not, is there a motion to approve the vouchers and the financial report?
So move.
Supervisor Jensen moves, Supervisor Kinnear seconds. Any other questions? Hearing none, all those in favor say aye.
Aye.
I,
I,
Carried. Does anyone have anything else? And hearing none, we are adjourned. Thank you, everyone.